So this is yet another video where I am going to guide you about especially about the residency. So this is so in the last 1 week I've got messages, calls from students from different colleges asking about my college review and what exactly the residency is like, and the major concern about them was, sir, if I am busy so much in my wards, if I am there in wards for almost 14 hours, 15 hours during my first year, if I am asked to do the blood collection work, if I'm asked to accompany the patient, if I'm asked to get the different procedures being done, so how am I going to learn during this procedure, and how much time do I get to read Harrison's, or how much time do I get to read and read about super specialty. So to address this, I'm making this video. So this will be primarily for the people who are just clear their NEET, want to is planning to do MD medicine residency, or people who are in the first year of medicine residency. So I have made few points to tell you how you should go through, or what is the best way to go through. So the first point is that you'll have to understand that the residency program is made for you to get exposed to the patients, not only the patients, so the presentation of the patient when he is admitted, the course of the patient, if the patient deteriorates, if the patient improves, and the other thing is, so for example, if you have a patient who is a case of disseminated tuberculosis, and now he has altered sensorium, so you will see a different spectrum of patients where you will find the different causes of altered sensorium in patients with tuberculosis. One of the patient could have hydrocephalus, other patient will have tuberculous meningitis, other will have tuberculous meningitis with multiple tuberculoma with vasogenic edema. So when you see all these patients inherently, or you will get immersed in the variety of the patient, so that you don't have to mug up things. You are going to experience them. You will see how the patient with a severe hydrocephalus, communicating hydrocephalus, deteriorates suddenly, and then he cones up and he dies if the intervention is not done on time. So based on this, based on your experiences, you are going to know how the presentation of the patient is, at what time, how you have to treat it. So this is the best teacher, or so the patient is the best teacher for you. So he is going to risk his life. The different natural histories of the patients, you will see it, and then you are going to learn it. So when you see patient in a emergency, in your wards, you will see the course. You will attend the rounds of your seniors, for example your immediate seniors, second years, then your third years. You will ask them about your basic doubts, that ma'am, why did you put this drug, ma'am or sir, why did you prefer this drug, apart from that, why are you using so and so drug. For example, when we don't have albumin, and we don't have drugs like terlipressin in the stock in the hospital, and the patients are not affording, so we a lot of times use noradrenaline and midodrine for patients with hepatorenal syndrome. So this is an adaptation to how the scenario is. A lot of times, especially in the government hospitals, the patients are not affording, and the must drugs are not, apart from the must drugs, we have to use a lot of drugs due to the variety of the patient and the multiple complications the patient present to us. So you will come to know how to see the patients, how to treat them according to the financial status, how to treat them according to the clinical staging of the disease, how to treat them on their complications. So when you see this, you are indirectly you are going to learn everything. So the second thing is, a lot of my juniors say that, sir, you have asked to do a 2D echo for that patient. It will take at least 3 years for me to convince the cardio registrar and then do a 2D echo. So the first point you'll have to understand is that when you accompany these patients, you are going to definitely learn about this patient. For example, you accompany a patient for an upper GI bleed scopy, and then you go and see, and you see that you have first time you have seen that the patient has a fundic gastric varices, and they have requested for a glue therapy for the patient, and you are asked to arrange a blood for that, and they are going to do a glue therapy and glue therapy for the gastric fundic varices. So you come to know that one of the causes of upper GI bleed can be a fundic varices apart from an esophageal varices. So you see that procedure, you see the live photographs or the video of the endoscopy, you experience that, you see how they are handling when they intubate the patient for a upper GI scopy, when they don't intubate, when you accompany for an unstable patient with an anesthesia backup and you see a colonoscopy there and a patient turns out to be ulcerative colitis or pseudomembranous enterocolitis. That is a different experience. That is the time when you can, when you make good friends, when you become friends with your SRs in different departments and you talk to them, you when they have time, they will indirectly, they will ultimately teach you before you tell something. So they are going to give you small tips about the patients, which patients to handle in what way, and what they commonly do about the patient, and you build up a bond between them. So for example, you go for a 2D echo and then the cardio registrar says you that go and auscultate that patient's murmur, and then he says this is a case of severe aortic stenosis, or this is a patient of RSD MS, and then you build up a connection with them, and then you learn things wherever you go. For example, if your senior has asked you to go and discuss a CT scan or trace a CT scan, so what you should do is you see that the patient has a cerebral venous sinus thrombosis, you go and talk to your batchmate there that what is the location of the CVST and what commonly they see, and apart from that, is there a venous infarct for the patient, and different things. You go, you see, if you see the patient as is a case of lung carcinoma with a pancreas tumor, and you see that there is a SVC thrombosis also, and then you clinically correlate that he has superficial dilated veins or he has Horner syndrome, then there is a different altogether process where you are going to learn, and this is going to consolidate your experience and your knowledge. So this is how you are going to consolidate it. For example, one of your batchmate who come from ophthalmology comes and checks fundus for papilledema for your patient for which you are going to do a CSF studies. Maybe he sees grade 4 papilledema, he might show you also, you talk to him, you see, you take the fundoscope, you see how exactly a papilledema looks like. So these are small steps how you are going to learn. We are not going to crib on things what we don't have control on. At present, I feel that we are like, especially I am in an institution where it is such a great support from the faculty, from I had from my seniors when I've been in my first year. So the work profile toxicity was minimal. So I had time to spend on my patients and see all the scenarios, and they were smart enough to guide me and tell me all the other things. And in general, that is only, for example, you are in the ward and the neurology or the nephrology registrar comes and sees your patient, and you give him small details which you know, which he might not know, and then you discuss him. He says this patient might need a Lasix drip or something else. So you'll ask him, sir, what is the Lasix drip? What exactly? When do we give it? So then you get a good connection, and then you get a good discussion between him, and then you learn new things. So a lot of things, if he is interested, if he connects with you, he is going to tell you other things. He will tell you, go and see that patient in my ward, we have a very interesting case. So this is how you learn it. You see one SLE patient, 2 SLE patient, and then I feel that if you have a good number of clinical findings and complications in that patient, I don't think that you'll have to go and read line to line from a book to write to treat a patient or to write in your exams as well. The third point is that I definitely try this is I carry a pocket notebook with me. So whenever I see something new which I don't know, or whenever I see a good case with new findings, with new complications, I write it down. So whenever I don't understand anything during my rounds or whatever is happening in that patient, I write it down, and whatever my seniors are there which are very accessible to me and which are very friendly to me, where I can message them at any time, I put the message, and then I get the reply in one or the other senior saying this is due to this reason it has been carried out. So the other thing is that I would like to recommend 3 things to be must for a first year resident. The first is a subscription to UpToDate. You will have it in your phone. You will download the offline data, and then approximately you will have everything. Even if you are in an area where you don't have network, you just have to open the app, and then you have to search about drugs. You have to search about. You can search most of the things, and I don't think that you can't read from it. it is so precisely given, and then if you read at the same time, you'll correlate with the patient findings and the reports of the patient, and then this will consolidate your experience. The other thing is ECG in Fastlane. This is a website for ECG, very crisply, very minutely explained about all the findings in ECG and in most of the cases. So very good for a first year residence. So even for the whole residency, I feel that I've learned most of my ECGs from ECG in Fastlane. I've gained confidence by seeing all the ECGs there. The other thing is Harrison's PDF. So when you get an idea where all the things are there in Harrison, what is symptomatology, what is cardiology, where is cardiology, where is immunology, where are acute rheumatic fever given, you can quickly see the PDF. You can see the algorithms to diagnose the patient, the algorithms to treat the patient in Harrison, and then you get a good image based memory for the condition. Other thing is what I do is, in the fourth point is that I collect ECGs, good X-rays, good ABG reports as well. I capture images of good CT scan findings and good MRI findings, and even some videos of the CT, MRI or the procedures which are being performed, because I feel that you build a good image based memory, and then if you have a good collection, I've been collecting almost 300 ECGs from my first year, with separate collection for emergency ECGs, separate collection for ward patient ECGs. In the ECGs in the emergency section, patient with acute coronary syndrome, patients with accelerated hypertension, LV strain, and the other parts with arrhythmia, different parts. So when you have those collection, and when you stick up a sticker there saying that this 45-year-old male had come with complaints of chest pain since the last 2 hours, anginal chest pain, and then you see the ECG. I have almost 7-8 ECGs only of inferior LMI, few of them with severe bradycardia, few of them in blocks, and so that is one spectrum of the disease where you capture with you, and then you consolidate, and this will definitely help me in my future revision during my exams. Apart from this is the most important thing which I feel, if you have good friend circle, you can discuss with your batchmates, make a group, try to be very clear that you are going to share all the clinical important findings, videos, photos of the patient reports and the findings, and then they are going to send you all the reports, and then you go and see those patients, you elicit the clinical findings, you see the CT reports, you see the MRI reports, you see what all management is going on with the patient, and this is definitely going to help you build up a knowledge. Because even if for me at this good institute at San Hospital, I've been very fortunate to see a lot of significant variety of patients, but then even in different units in the hospital, I've seen that there are significantly unique cases. So it is important for you to be connected with your batchmates, see their good cases, so that you try to see unique patients, and then you build up your confidence. So in the last, I have to say you something is that you are going to be a physician, and to build up a confidence for you to treat a patient, you have to see patients. It is not about reading Harrison's, it is not about reading Brownwolds, it is about seeing patients. If it is about talking to patients, it is about examining the patient, it is about reading the reports, correlating with how things can be